what's up, everyone? John Heringer, Chief Motivator at Method 3 Fitness, and welcome to another Stronger for Today show. We're excited to welcome my guest today. Her name is Kim Pittis from SFM Sports, and she's been in the sports therapy field for over 20 plus years with extensive experience in manual therapies, exercise rehabilitation, and training, and is now an instructor of frequency specific microcurrent application in physical therapy. So we're going to dive into a lot of great stuff. What I love about Kim in this conversation is that she really doesn't want to focus on just the symptom-based treatments. She really tries to uncover what the dysfunctions are within each individual, lots of listening, lots of assessments, lots of collaborating with other practitioners as well, whether those be physical therapists, orthopedic surgeons, or even trainers and fitness professionals. She's a creator and director of SFM Sports and is a co-instructor of the pain injury FSM modules, which provide training to physical medicine practitioners on the application of SFM in sports and rehabilitative medicine. I'm excited to dive into this. I know you get a lot of great value. So without further delay, my conversation with Kim. All right, Kim, thank you so much for joining me today. Pleasure to have you here on the Stronger for Today show.
Thank you for having me. Always excited to talk shop.
Yes, absolutely. So I want to first start actually. So we were introduced by Coach, I call her Coach Mira. You may just call her Mira.
Yeah.
And I'm curious, can you just remind me again kind of how you guys know each other? I think it's from the hockey world with your kids.
Yeah. Way back when, gosh, it's amazing how fast time goes by. But our daughters were on the same hockey team, playing for the San Jose girls Sharks team. So that's how we were introduced. And yeah, we were both very knowledgeable, I think, and active in our what we think was beneficial for our kids' recovery and training. So we had a shared love that sort of grew very quickly. You know
That's
how that
awesome.
happens.
And
Yeah.
then we were chatting a little bit prior. I think you had mentioned that you actually assisted with some of the, whether it was the training or maybe some coaching or some recovery modalities or
Yeah,
things for the kids.
I like I said, my kids were always my biggest billboards. So when anybody was complaining in the locker room about something hurting, they would always say, you should go see my mom. And I think, working with professional athletes, I really don't see a difference between the pros that I work with and the teenagers that I work with. This is somebody who wants to get better and will listen and will do whatever it takes to improve their performance. And I know we'll kind of get into more of that with all the different types of populations. But yeah, I think I was helping out with, one specific knee injury maybe, and then that sort of morphs into, okay, well, what are you doing at home and what's recovery look like and what's diet look like and do we do breath work and mobilizations? So, and then I started, yeah, trying to offer it to everybody, not just the broken hockey
Yeah,
players.
sure. Right. Well, that's awesome. And it's evident that you're obviously very, passionate about what you're doing. I know you're still in practice today after how many years of this?
I'm going on 26.
26.
Yep.
Fantastic. Love it.
Yep.
And so I'm excited to kind of introduce people because I think many of them may or may not know about FSM, which stands for Frequency Specific Microcurrent, correct?
Yep.
Type of
Yep.
modality and therapy that you specialize in. So for a lot of listeners out there that haven't heard of it, don't know what it is,
Mhm.
can you elaborate on what it is, how it's used, and then we'll dive into more from there.
Yeah, sure. FSM, like you said, frequency specific microcurrent is a modality. It is a device that we use as an adjunct. I say it's the world's best adjunct because it's not a device that you just plug yourself into for an hour and everything gets better.
Yeah.
It was initially, I wish it would,
Sure.
but it was initially developed, I think, in the late 20s by these osteopaths who were using a lot of radio frequency, light, and so it's not new, but it's kind of coming back into popularity. Like I said, I've been using it since 2009 is when I took my first course in FSM. And now I teach it to practitioners. So like I said, it's a device that patients can use by a trained professional who's taken some courses and how to use it. And it's unique in the fact that it requires the practitioner, the administrator, the clinician to think about what tissue is involved, whether it's a muscle, labrum, tendon, nerve, artery, vessel, kidney, and then match that up with what they feel, what the hypothesis is with the pathology. So inflammation, scarring, adhesions, so on and so forth. So the practitioner is thinking about what's wrong and where is it occurring, and then using assessments, biomechanical, doing a very thorough patient history, reflexes, you name it. So many of our practitioners come from different backgrounds, whether it's an MD, chiropractor, PT. So they take kind of their assessments. We show them how to use our assessments as well. And then they use frequency to help with what's going on. So if it's scar tissue, combining it with manual therapy to help break down the scar tissue so it's not as aggressive, helping with inflammation. I'm working with a orthopedic surgeon in San Jose 1 day a week. We've been kind of knocking it out of the park with his perioperative results for a few years. So I'm really happy to join his practice,
Great.
especially with the world of orthobiologics, where you can't use an anti-inflammatory right after. So using FSM, using frequencies to help with soreness and help mitigate inflammation that when you can't take an anti-inflammatory.
Because I heard a lot of things there I want to kind of dive into. So when you have a patient in front of you, obviously, like you said, there's a huge medical history and just questionnaire and things like that that you're getting from them. Being a great listener obviously is important. I know you mentioned that. What does the assessment part look like when they come in talking about, hey, I just been having issues in my, I don't know, right knee or my low back on this side, right? And then, through discovery, you discover something else. What does that look like?
Well, I think initially, I go back to basics. So I was trained very heavily on the osteopathic model where gait and standing assessments were king. And I think we get it wrong right off the bat. Having somebody do a gait assessment, nobody walks the way they normally walk when they know somebody is watching them.
Right.
So my gait assessment is when I greet them in the waiting room. I purposely don't want people coming into exam rooms because I want to see them walk towards me. And then I want to trick them and say, actually, let's go to this room instead to start. And then I want to see them from behind. So I want to watch people walk when they don't know that I'm watching them walk. I want to see them stand when they don't think I'm evaluating them. So I'll purposely pause to see, are they heavier on one side? What does the forefoot look like? Was there a hip hike? And it's not a specific exam, but I think these types of clues can really start leading us into what some of those compensatory patterns are like. And then I am a big collaborator. So I want to know who's their trainer, who's their PT, who's their chiropractor, and what have they seen. So I will always call their trainer. What are you seeing in the gym? What can't they do? What lights them up? So I think we also get it wrong thinking our assessment is the only way. I want to collaborate and get as many pieces of information as possible. With my pros, I want to watch game tape. I want to see them run. I want to see them skate. I want to see them catch a ball. I want to see them in their organic fashion. So when I'm
Yeah.
educating people on how to assess them, I'm actually kind of I'm saying, don't do this. Just
Yeah.
watch them when they're not watching. And then of course you have to do specific exams or at least, ruling out pathologies with orthopedic exams to make sure that something isn't wrong with the meniscus, so on and
Right.
so forth. But
Right.
I'm very much in a team when I'm working with athletes and patients. I'm very much part of a team and I want to stay part of a team.
Yeah. I love that. I mean, I think that's, unfortunately, I think many practitioners kind of operate in this vacuum, I guess, where it's like, they're this the holy grail of this is what I do and this is always right and this is the way. And while I applaud the enthusiasm of that, I'm definitely a little bit more on board with what you're saying is that it's a collaborative approach and that, I can be we can kind of be experts over in our lane over here. And then we'll happily collaborate with others like yourself and PTs and the orthos and whoever it is to make sure that we're serving this person best, right? We're saying, hey, we can do this part. And then this person over here is probably going to do this part. Or tell me what you heard over here, Kim, so that we can, because then it becomes an ongoing dialogue with how to serve this person best. If we give you some
Right.
info and then you work on them and you say, here's what I saw. So here's what you probably want to include or not include in their training program. Awesome. Now we're really
Absolutely.
helping this
Yeah.
person, right?
Yeah, that is, and you are totally right. We are definitely kind of in this like gatekeeping mentality. Those of us who have been in our industry for a while have kind of seen it. But when you put yourself as a provider second and you do make it client focused first, I think that's when you do find the team, right? And that team approach does serve the client best. So if you're truly in it to see them improve, whatever that improvement metric is, you need the team.
Yeah. So what would you say, Kim, typically, and I'm sure this kind of runs the gamut here, but let's focus on, because a lot of our audience is going to be the older adults, so 40, 45, 50 plus. What do you see typically that people in that demographic will come in to see you for? Is it pain? Is it scarring? Is it post-op? Is it, what does that look like? I'm just curious.
Yeah, and I think it's kind of a combination. I do see a lot of active people. So I whether that's a professional or an amateur athlete or somebody who's my octogenarian that's still running marathons. I'm in the business of keeping everybody moving as long as humanly possible.
Love it.
We're meant to move, right? And so any provider, and all this is the hill I will die on, but any provider that says, okay, you need to stop, I'll tell my patients and clients, go find a different provider
Yeah.
because we might need to pivot, we
We
might need
say
to
the same thing.
modify,
Yeah.
but yeah, we're never gonna stop. We
Right.
never want to stop. So I mean, I do see a lot of hip and knee. That does seem to be sort of like, if we're looking at like common areas, those do seem to be an area where if I had to pick, although there is a whole bunch of frozen shoulder in the perimenopausal women population that I see. Is it pain or is it immobility? I think it's probably a combination of both. I think the really active, especially like ex-competitive athletes, we don't use pain necessarily as a guide because I think they have learned to blow through the stop signs. So maybe the mild pain that they had in the ankle, they run through that and all of a sudden they have significant pain in the opposite hip or knee or
Yeah.
something. So it's a combination of both. Performance tanks, fatigue hits, pain. I think for me it's hard to kind of pick one of those.
Gotcha. Okay. Fair enough. And then you mentioned, for some of the things as you're kind of collaborating, doing the detective work, yeah, kind of figuring out with that person what exactly they need. You mentioned some things previously like adhesion or inflammation
Mhm.
or scarring.
Yep,
So,
yep.
how are you kind of investigating and finding some of these things? I'm sure some of it's with what they're telling you, but just whether that's via touch or kind of like a movement with them. And then I'm curious, once you find it, how do those therapies differ? Like, what does that look like as they're actually working with you?
Sure. I'll just kind of give an example maybe with the hip or knee. So when somebody's saying, I've got some knee pain, right away I'm thinking, okay, well, we're going to rule out an orthopedic issue, whether it's meniscus or ligature, and we do some tests to make sure that looks normal. And then we're going to do biomechanical assessment. So knee flexion, hip extension, where we can kind of rule out, is it a tight hamstring? Is it a tight quad? Again, based on kind of a biomechanical assessment, or maybe there's a weakness there. Maybe something's not firing. But again, it's not stopping with, okay, it's not firing. Why is it not firing? Like that is kind of the bigger question. Why would something not be online right now? I think we're also in this terrible sort of garbage can diagnosis phase of everybody has quote unquote weak glutes. Well, I went to PT last year when I had some hip pain. I run half marathons, and the PT that I went into said, well, you have weak glutes. I don't have weak glutes. I run 30 miles a week.
Yeah.
That is not, and I put my shoes on and he's like, "Well, where are you going?" And I said, "I'm leaving because somebody that just slaps something on it says you have weak glutes. I don't think we could work together." So, I'm not discounting there could be a muscle, maybe glute med isn't firing the way that it should have, or glute min or something else, but I want more. And I think we have to give our clients more. So going back to my assessment, biomechanical, strength tests, palpation, if I'm finding an adhesion, maybe that's the reason why that range of motion looked limited.
Mm,
because something was sticky. And those of us over the age of, I'm going to even say 35,
yeah.
we're going to have adhesions. We're going to have scar tissue, especially those of us who are really active in our 20s. Things get bumped and bruised and they don't heal the way in this beautiful linear fluid fashion.
Right.
So, and then that's where kind of where FSM comes in into play to help me mobilize tissue.
Gotcha. So, and how are you using that kind of in a session? Obviously, I'm sure, like you said, some manual therapy as well. But where does the
Yeah.
FSN come into play as you're doing that?
Yeah, right away, right off the bat. So as soon as I let's just go back to that trigger point. Let's just say there's some scarring in between the hamstrings that we have to get at. So we apply the FSM either with kind of like the sticky pads that you would apply a TENS machine with, or and what I like to use clinically is we clip the leads onto wet towels. So the deep moist heat goes through the skin into the fascia a little bit faster. And then
Mm,
we just kind of create two fields, a positive and a negative field. And then my hands are free to mobilize the tissue in between the two fields of FSM. So again, most clients will just feel what I'm manually doing and
mm,
then nice warm towels on them, not
right.
necessarily the effects. But I can feel the tissue relax a lot faster than without FSM.
Gotcha. Okay. And then once they're done with that session, whether it's like the inflammation or the adhesion, what the goal is to, ultimately reduce the pain or restore the mobility or things like that, right? Is that, and then they're
Yeah.
coming in to
Yeah.
continue that. And then from that, hopefully getting some information from you or their PT, like, great, now that we have that done, maybe now you're saying, now we got to get these muscles that were inhibited kind
Right.
of back in the game
Totally.
so that we
Yeah.
can hopefully minimize it.
Exactly. The world of FSM, especially when it comes to breaking down scar tissue, it goes very fast. So, like I said, I've been in practice 26 years. I remember practicing without it. I knew how long a session would take to break down scar tissue, mobilize them with stretching, whether it was like a PNF stretch or just static stretching. And FSM works so quickly. So, a lot of the other kind of flip side that what we do with FSM is corrective exercise or mobilizations with current running. So then they're moving through a movement pattern and, working with their nervous system as opposed to just the connective tissue to help get those muscles back on board. Especially if somebody has been in chronic pain or has had a condition for a long time, their nervous system has a very strong opinion about what
Mm,
had happened. And that safe to move feeling may not be prevalent. There may be a story there that says, if I do this, if I raise my shoulder above 90, it's going to hurt. Well, what if it didn't? What if we broke down all the scar tissue and the adhesions that were in the subscap area and now your arm can move and it won't hurt? So people will say, like on the table before they move, oh, this is going to hurt when you retest it. And I'm like, why? Do we know that yet?
yeah.
Could it be pain free? So sometimes it's patient education and
Mm.
approaching something with curiosity as opposed to this is going to hurt.
I want to reflect on that with you because I literally just spoke about that with another guest I had, Dr. Millard, that worked on my back actually. When I went down the rabbit hole of some pain science and that whole aspect of it's wired, our brains are wired to help keep us safe. And that's related to our movement patterns as well. And it was uncanny to me how, we transfemoral epidural, inflammation gone off the nerve, started physical therapy. And, I forget how long, I don't know, 4 weeks, 6 weeks in. And when I would just try to do a simple, you know, bowing, hinging, trying to just like slide my hands down my thighs to like do a toe touch or something, right? I would just stop. It's like I hit this barrier. And I think my brain was literally like, "Hey, pretty sure that maybe doing some, single leg RDLs is maybe how you hurt yourself. Probably don't do that." Right. And it was unbelievable. Like I literally, my hands would get past my kneecaps and I would just stop. And I'm like, what is happening? There's no pain. And so it literally took, whether it was, scar tissue built, whatever it was, but we, a physical therapist, God bless him, we worked through it where he would just help move my body into that, position, so to speak, to help retrain my brain that it was okay to be here.
Right.
so amazing to me. And I think so many people are stuck, whether consciously or unconsciously, that like, if I do this, this will be painful, right? And to your point, it's like, well, do we know that actually? Like, what if we do
Right.
some of this work and then we retest? Can we just be curious and just find out if that's still true? Yeah, it's so crazy to me. So that is neat that you're helping people really work through that, because I mean, I'm sure that's a roadblock, especially for, the 35, 40, 45, 50 plus market, because they're scared of injuring themselves again, right? I get it.
Totally. Yeah.
That's neat.
The work started, with professional athletes because the confidence is king, right? They cannot afford to be worried about coming back from an injury. And that urgency that I felt working with professional athletes is kind of what brought me to doing that work with everybody. And especially, like you said, the older population that could be living in fear just day to day, going down the stairs, lowering themselves to sit down, going to the bathroom. So we talk about like the squat all the time. And people are like, but I'm not an athlete. I don't squat. I'm like, oh, if you sit down, you squat. If you
Yeah,
sit on the toilet, you squat. So we need to make sure that this movement pattern feels really, really safe to you because there's
yeah,
no reason why it would hurt you anymore.
right.
So yeah, it's we want to keep people moving, but it's not just keeping them moving, it's keeping them moving confidently.
Yep. And to that point, like you just mentioned, the athletes, they've got this different, I'm gonna say, internal and external, like, motivational factors, right? That there's this confidence that drives them. They need that. They need it for their sport. They need it for, especially if they're a professional athlete, like their careers literally depend on it. So they're motivated to get in there, get the work done, and do what needs to be done. The common, you know, general population isn't many times. Have you found any ways to help them tap into that same level that the athlete has, to try to bring that? You mentioned level of, like, sense of urgency, and it's a bummer sometimes that many people don't carry that with them, and they're just kind of like resigned almost to the fact that, like, this is just the way it's going to be for life, and you're like, it doesn't have to be, actually, right?
Right, right. I think what you just said, sprinkling that it doesn't have to be like this. I think some people come in and they'll literally say, "I have tried everything." And I'm like, "Great, let's go down that list." I would love to hear what, because
Mm,
chances are they have not tried everything.
right.
And there's always a spectrum of what they've tried. Well, I've tried chiropractic. Okay, great. I know 6 chiropractors that all have a bit of a different technique. Like
Right.
what worked, what didn't, right? So kind of breaking down what they've tried. But going back to that sense of urgency, I think if you ask the right questions, you can find that sense of urgency in everybody. So I will say, when this injury is healed, what is the first thing that you're going to do, or what can't you wait to do when this is resolved? And sometimes it's like, I can't wait to pick up my grandson, or I
Mhm.
can't wait to push a grocery cart again. Like there's a
Right.
movement pattern everywhere. We just have to ask the right questions as providers, what they can't wait to do. If it's picking up a baby, let's break down that movement pattern so we can pick up a baby. And then you'll see their face change, right? They're
Yeah.
talking about their loved one or their animal or painting or something. But let's bring them back to that activity of daily living. It doesn't have to be their sport. But I firmly believe nobody wants to live in pain or immobility. So I think we just have to ask better questions.
Agreed. And I think sometimes, there is yeah, I don't want to say misconception, because it's partially true, right? You get in there, you do the work, whether it's with you or with us or a PT or someone else, like, there's going to be some possible discomfort as those muscles get realigned and
Hmm.
unadhered and stronger, and now they're sore. And so there is something to be said about that doesn't resonate with everyone. Uh,
Hmm.
and I think sometimes people get in their heads that it's going to be a lot worse than it actually
Right.
really is, right? And that
Right.
they're easily forgetful, or just not willing to look at all the benefits that will get derived once they kind of continue on that path. So I'm curious, Kim, thinking about these older adults that come see you, do you see specific movement pattern dysfunctions in many adults? If so, what do you see those typically be, or what do you see those typically are? And then, kind of aligned with that, right? As a result of how they've moved prior, are there certain mistakes that you see people making as it relates to like how they move? So certain dysfunctions that you maybe see, and then certain ways you're like, "Ah, probably related to these mistakes they're making with their movement patterns."
Yeah, I hate generalizing as a rule, but I
Fair enough.
mean, we are super like anterior chain compromised right now. Like everything we
Mm,
do is in front of us.
yep.
So, sitting, we know this one of the worst things structurally that we can do for our spine, whether it's our discs or our hip sockets.
Mhm.
So I feel like getting people out of a chair as much as possible and taking breaks. A lot of us are working, longer. So sitting at a desk is terrible.
Mm,
So I want to get somebody out in and out of the chair as much as possible. Standing desks are great, or just setting a timer so that we can like stand up, move around, walk around. So with that anterior chain sort of dominant, so we have like the shortened, hip flexors that adaptively shorten because we're sitting, our glutes, we're sitting on our ischium. So we have these like tendinopathies coming up by our hamstrings. The discs are squished because we have all this force transmitted through our lumbar spine from sitting on it. And now, and I don't even want to say older adults, we're seeing this with like younger adults, this
mm,
anterior neck posture because everybody's on their phone all the time.
yeah.
So these movement patterns, based on kind of that sedentary lifestyle, I think is something to watch for sure. And like the antidote to maybe be a little bit, hypocritical of what I just said isn't just standing. We have
Mhm.
to begin to like strengthen our posterior chain, but the posterior chain, if we're an athlete and I'm saying, "Okay, get ready," everybody's gonna go into this kind of forward braced, ready position, right?
Yeah.
And that comes back to our caveman days, right? The saber-toothed tiger is coming into our cave. We're gonna protect our organs. We're gonna kinda curl up. Historically, going into this, like, extension position leaves us quite vulnerable. So
Mm,
it's sort of a hard movement pattern to feel safe in because we feel very exposed and vulnerable when we're activating our posterior chain. So I think again, it's just doing it in a way where we feel safe to activate and to really kind of break down what is somebody doing all day long that is
mm,
going to undo the hour that you spend with them during your appointment time. Like
yeah.
we and like as clinicians, I think it's really hard because we do so much work building the program. We bring our enthusiasm when we're meeting them and they do everything great when they're with us. But if the other 23 hours a day they're undoing what we're doing, we can't expect anything to stick.
Right. So are there, and again, not to make you generalize more, but are there, I think some people, and to your point, I do love that because every person is different. Every person's body is different. What they're coming in is different. And I think there's always some key takeaways that people can, that anyone can implement and probably move the needle in the right direction, right? Like, can I stand a little bit more? Can I work on some posterior chain muscles, right? Can I get a little bit more into this vulnerable position? If even just moving my body that way. So I'm curious, are there, you mentioned at the end there, we're trying to make sure they don't undo what you just did, right? Any practitioner is trying to help hopefully make sure that happens, right?
Yeah.
Have you found there are a couple key things you'll instruct people to do kind of across the board that you see move the needle in the right direction to help maintain the integrity of, the session that was completed?
Yeah, I love balance work. I think proprioception and balance work is grossly underprescribed. I think if anybody has blown the needle in the right direction or has like expedited recovery or gone back to return to play or just gone back to pain reduction, it has
Mm,
been the people that are doing proprioceptive work. And as we get older, we know that our proprioception starts to tank. And, it's a story of like, I fell and broke my hip and it was something so stupid. I just
Hmm.
stepped off the curb wrong. And like, I'm just automatically thinking, our reaction time really starts to slow down.
Yeah.
So can we work on that now? Can we front load it? Can we implement that? So many proprioceptive drills that we do are so safe. So we can build that into, post-op work. We can build that into anybody. Even if you're sitting down, I'll say like close your eyes and lift your foot up and down off the chair. And they're like, "What? That's all I have to do?" And I'm like, as a start, yeah, just to
Yeah.
feel where your body is in space without you looking at it. Just kinda strengthening that mind-body connection. So, yeah, across the board, proprioceptive or balance work is kind of my non-negotiable.
Awesome. And you're right. I think it is pretty underprescribed. We try to pepper it in to some of our programs for sure with some of the accessory work. And I think people forget too, like you said, it can be as easy as you just said. Or if they want to, make sure it's done, I try to pepper those in as like an active recovery in between strength sets,
Yeah.
right? Just,
Yeah,
something
totally.
that's
Yeah.
awesome.
Yeah. You
So
could do that. Yeah.
go ahead. Go ahead.
No, I was gonna say, like, when you're doing that with the trainer in person, I think you get a lot of benefit too because you have another set of eyes saying, "Hey, did you know that when you close your eyes, you actually do this?" But doing reps at home, that is like you can incorporate that into your day, right? The last thing people need is another thing to do
Right.
at home. So, well, you're gonna brush your teeth. Why don't you close your eyes and stand on one foot? Or get this foam pad on Amazon, and if you're gonna stand and peel carrots, why not stand on the foam pad for a bit?
Yep.
So,
Yep.
splicing
That's
it in. Yeah.
so I want to touch on some recovery here in just a second, but first, I'm sure some people, again, over the years, different compensation, things like that. I know just with certain method 3 partners, they'll have what I would assume, but I'm not an expert like you, is maybe just certain adhesions. But it's almost like knots in their body in various muscle groups. A lot of times up in near the rhomboids and traps. But something where it's like, hey, even using a little bit of a Theragun in and around the area, or in alignment with where the muscle fibers are moving, like there's only so much we can do with that. And then I'm like, huh, I don't really know where to go with that. Have you encountered that before? And kind of even a massage therapist, I'm like, wow, it probably would take you numerous sessions to get through. So I'm curious, have you encountered that? If so, and I'm sure that's a dysfunction that if we can alleviate in some capacity, right? We understand that it's not pathology wise, it's not a cyst, it's not, it's muscular in nature, so to speak, but it's just wound up like this. What have you done in those cases?
Yeah, so the rhomboid, so that's, that area between the shoulder blades, people will always complain, and say that, my rhomboids are tight or my traps are tight, and I'm like, they're actually not." And people are like, "What are you talking about?" Well, if your rhomboids were tight, you'd be walking around in retraction,
Yeah.
and nobody does that, and in 26 years, I've seen one person with truly tight rhomboids, and she was an Olympic backstroker.
Mm,
So, we don't live in extension. Like I said, we live in this like
yeah.
forward flex position. So those rhomboids and those mid traps actually get stretched, right? And then you get slips of them that try to contract, that try to be good and try to pull us back. But, posture is king, so it takes over. So we get these localized areas of contraction that stay tight, and then if they're not mobilized properly with soft tissue work or with stretching or with yoga or myofascial release, then they get harder and harder and harder. And then you start throwing age into the mix. And then things can almost get fibrous or calcified.
Right.
So self myofascial release can be a wonderful tool to get kind of pressure in those localized areas to reintroduce blood flow, circulation, those macrophages, the cleanup crew that come in and get rid of debris. So, Theragun, I've seen, because I'm on the other side of things, I've seen people hurt themselves because they're Theragunning the wrong areas, like tendons or
Hmm.
bones that can hurt. So, as long as it's done kind of in the juicy area, those vibratory tools can be wonderful to help introduce circulation, heat, blood flow, which is what those areas truly need. Massage. I remember once upon a time, Coach Mira was teaching like these self myofascial
Yes.
classes. Like those are wonderful. Like,
Yep.
so get your hand in the little rubber balls and roll around on things. So yeah, really useful tools to help.
Awesome. So let's extend upon that then and kind of talking about recovery. I think a lot of times, like you said, if you mentioned earlier, people think, oh gosh, if I have one more thing to do, right? And it can definitely always feel like that. So I know when we talk to our partners, it's always about understanding from them what they're realistically willing to do. How can we habit stack, things like that? If you had to, touch on a few key pieces, well, I guess number one, what role do you think recovery plays in healthy aging overall? And what are a few key things people can focus on within recovery that they may be able to implement within their weekly routine?
Yeah. So it recovery is everything. You could be the best trainer at the best facility, but if people are eating like garbage and they're not sleeping and they're not doing, some extra things, they're just not going to be able to train harder the next day. You kind of touched on it. We're going to train really hard on Monday. We're probably going to feel sore on Tuesday. And to approach that feeling with, that was a good workout as opposed to hitting the panic button and saying I'm injured. So like we want to mitigate that delayed onset muscle soreness. FSM is a great recovery tool. So a lot of my athletes have the home units they take home after a hard workout. They're going to run some of the frequencies to help with that inflammatory process, but the mindset has to change. We have to look at our bodies kind of like my 2013 Forerunner. It needs a little bit of maintenance to keep running. That is just the nature of having an older vehicle.
Yeah.
So we have older vehicles that we're in. I run competitive half marathons. My recovery today, my warm up today looks completely different than it did 8 years ago when I started.
Yeah.
It That's just what my body needs. So I don't wanna say, like, you have to do X, Y, and Z at night, but maybe again, it's rephrasing it to say, well, to have the best benefits, can we change or modify some of the things that you're doing at home to set you up for success a little bit better?
Mm,
So those Theraguns, going for a massage, using FSM, saunas, just going for a walk after dinner, helping your
yeah.
digestion, mindfulness, stress reduction, but the really the biggest thing if we're having the recovery discussion is sleep. So we really need to make sure that we're sleeping at night. And sometimes changing the sleep hygiene is the hardest thing for somebody to change. We're so used to falling asleep watching movies or scrolling on our phone, going to bed way too late. So that human growth
Mm,
factor that we need for repair isn't even kicking in because we're not
yeah.
sleeping long enough before midnight to get it. So sleep, I think. And I mean, and there's 1,000 supplements that you could take, and the world of
Right.
peptides is probably a whole other podcast. But
Yeah.
I think we
Yeah.
have to be able to control what we have at home that's free, and that is that's sleep.
Awesome. Awesome. Yeah, I agree with everything you said. And hopefully, for people that are listening, there's at least a few things you can snag from that you can implement. Many times, I know it's human to just kind of want to try to do everything and get the absolute best result. And most of the time, that's just not realistic. And I'm a big believer that success begets success. So if we can be successful at a few key things that are kind of in our wheelhouse or easy to implement or easy to do in our routine, then we can always layer on and add more. Right.
Right.
Kim, this has been awesome. Love the discussion. Love what you're doing. How can people reach you if they want to reach out? We've obviously got a lot of people in our San Jose community. They're going to be watching this, listening to this, a lot of partners in Method 3. What's the best way they can reach you and how can they connect to find out more?
Yeah. So the website fsmsports365.com has a lot of information there. I'm at the Mossy Clinic in San Jose. So Mossy Clinic will have some information on FSM pretty soon. It's kind of a new addition there. But fsmsports365.com is probably the best way to get a hold of me and look at the two locations in San Jose and Livermore right now. Yeah,
Awesome.
that's probably the easiest way.
Perfect. Well, thank you again for all the information. We'll put all the information in the show notes as well. So you guys can get a hold of Kim and just add her to your arsenal of recovery and everything else you need to kind of keep moving and living stronger for today. So, Kim, thanks again for being on the show, and we'll talk to you
Thank you
soon.
for having me.
My
Great.
pleasure.